Hi, this is Penny Shelton, the Executive Director for the North Carolina Association of Pharmacists. Today, what I'm hoping to do is provide you with more information about the bill that we are running that would modernize our existing collaborative practice authority. I'm hoping to be able to present you with information about the details of the bill, as well as to share some information to answer some questions that have been raised by various pharmacists in the state. And then we're going to provide you with a panel list of individual pharmacists from across the state answering some questions. And then finally, what I would like to do is provide you with contact information where you can submit questions, comments, or suggestions regarding this bill here at NCAP. I'm going to turn off my camera at this point, and then that way you can see all the slides in full detail. And we'll get started. So first of all, the bill is, one of the things we think about is when we're running a bill, what are we really, focused on? What are the concerns? What are some of the driving issues behind that? So one of the things that has been raised is that here in our state, our Division of Public Health has really talked a lot about the chronic disease burden that our state is facing, some of the public health initiatives that are really rampant across our state, such as the opioid epidemic, continued rise in tobacco use, and then really one of the things that has been greatly discussed is that there's tremendous interest in the fact that we have a number of pharmacists in our state that are strategically positioned within our health systems, within our communities, within various patient care settings. And how could we better utilize those pharmacists in helping address chronic disease burden? Now, this slide here is really referring to the chronic disease burden that we're seeing nationwide. But really thinking about just North Carolina, we know that we have high levels of heart disease, cancer, and diabetes, as well as other chronic comorbidities. And quite frankly, it's a huge cost burden on our health system here in the state. So as we talk about the modernizing of our collaborative practice, try to keep this in the background of your thoughts as to how pharmacists could better utilize collaborative practice to be able to help with some of these needs that have already been identified by public health here in our state. So also in setting the background, this is a slide I like to use to sort of just, sort of drive home what is the current state of healthcare here in North Carolina. So we know we're dealing with a rapidly increasing chronic disease burden. We know that we're seeing steadily increasing cost of healthcare as well. A couple driving factors for that in more recent time has to do with our aging population. As more baby boomers age into the era of Medicare, we are seeing increased disease states that we're having to manage. And then the other thing is, as I already mentioned, is the opioid epidemic. So with substance use disorders being a chronic disease, this is also fueling some of that rising cost to our healthcare system. So in addition to this rising chronic disease burden, we also know that on the right-hand side of the slide here, that the United States Department of Health and Human Services projected a nationwide physician shortage, particularly in the area of primary care and particularly in rural areas, that shortage was projected to be, as I mentioned, nationwide by the year 2020, which is already upon us. However, there is a more recent report that came out from AAMC that actually released new data showing that the shortage of primary care physicians, particularly in rural areas, by the year 2030 was to be worse than expected. North Carolina, a large percentage of our state is considered rural when looking at the parameters that define whether an area is suburban, urban, or rural. We know that a large chunk of our state is actually defined as rural. Then on top of that, there was a George Washington University study that came out last year, where they were looking at nursing shortage, and North Carolina is projected to have the second largest nursing shortage by the year 2025. So, and when we look at our citizens, there are a little over 10 million citizens in North Carolina. Almost 2 million of those live in what has already been defined as healthcare professional shortage areas. So the projected shortages coming our way will only worsen the situation for us. So what can we do, and how can we collaborate to actually help share in the care of patients and citizens in our state? And that's what modernizing our collaborative practice bill is really about, and what we're trying to do and targeting the change. So the National Governors Association, the Patient-Centered Primary Care Collaborative, the CDC, and CMS have all put out statements within the last few years. Basically, their statements have centered around this rise in the burden of care, rise in cost, the shortages that we're facing in healthcare workers, and then also just that whole shift to value-based care. Trying to get all healthcare professionals to practice to the height of their degrees. So all of these organizations have called for and/or recommended greater utilization of pharmacists in patient care, and also advocating specifically for physician-pharmacist collaborative care as an efficient and effective means for providing care of patients that have chronic ongoing conditions, as well as they've also called for removing unwarranted barriers or restrictions to collaboration. So calling on the states to look at how they conduct collaborative care and do what they can to actually better facilitate collaboration among pharmacists and physicians in the states. So we know that when physicians collaborate with pharmacists, that pharmacists help improve access to care. We know that when pharmacists help manage chronic disease or provide maintenance care, that physicians are better able to dedicate more time to patients that are more acutely ill or complex or brittle. We also know that by partnering with pharmacists, that pharmacists help build care capacity. And specifically, when we think about building care capacity, we think about the provision of new types of services which improve the access to care as well as the quality of care for patients. So an example of that around the opioid epidemic would be physicians and pharmacists collaborating to build new care capacity in the context of providing medication-assisted treatment for addiction. So quality of care is another area where we've got plenty of data. The literature supports that when physicians and pharmacists collaborate, the quality of care, typically measured by patient satisfaction, physician satisfaction scores, are higher than in control groups where there's not collaboration occurring. We also have plenty of literature that supports that pharmacists actually improve patient outcomes. We see fewer medication-related problems. We see improved primary outcome measures, such as with things like blood pressure and blood sugar. And when we also see fewer emergency department visits and hospital readmissions. This figure also on lowering cost of care, we've known since the days of the Asheville Project, dating back more than 2 decades now, that pharmacists collaborating with physicians and pharmacists involved in patient care can actually help lower the cost of care. And so this particular cost ratio here of 10 to 1, where for every dollar spent there's a $10 savings, is actually data going back to that Asheville Project. And then we have a plethora of data in the literature regarding the cost savings that pharmacists bring when they're collaborating with physicians. A newer set of data actually centers around when physicians and pharmacists collaborate, the pharmacists help with physician resiliency. So when we're already facing a physician shortage, particularly in the area of primary care, we know that there's a growing area of data or literature supporting that when pharmacists are collaborating, that we see greater physician satisfaction or job satisfaction because of the care burden being shared, and therefore there's less physician burnout. So what is the state of physician-pharmacist collaborative care in North Carolina as of right now? So North Carolina in the 1990s was one of 3 states that really championed and pioneered collaborative care, along with Washington State and New Mexico. So collaborative care, essentially, when we define that, regardless of what state you're talking about, we are talking about when a physician delegates or authorizes, typically through a written agreement, certain patient care acts that the pharmacist can provide. And those patient care acts could be things in the area of assessment or in monitoring or adjusting drug therapy. It could be around ordering labs for a condition. Essentially, whatever is spelled out in the written agreement, the physician is able to delegate and authorize the pharmacist to carry that out. In North Carolina, we conduct collaborative care under our clinical pharmacist practitioner statute, which dates back to 1998, and the general statute number is listed here, as well as the primary rule with the North Carolina Board of Pharmacy is listed for your reference. Well, what is the state of the clinical pharmacist practitioner utilization in North Carolina? What does that look like? Now, this data is data from September of, late September of 2018. The first, to set sort of your pool, at the top of the pyramid where the green bar, we have in our state more than 15,000 licensed pharmacists. But if you remove, if you take from that picture individuals that have a license here but don't work or reside in North Carolina, or if you take away retirees, you're basically left with greater than 12,000 pharmacists working, residing in North Carolina. So of that 12,000 plus pharmacists, 294 were listed as active CPPs with the North Carolina Board of Pharmacy. The vast majority of those are affiliated or employed or part of a health system, and many of them in clinic settings. And there were very few that were in the community setting, and there's actually 0 that are in long-term care. The vast majority of CPPs are in urban areas, which kind of makes sense since most are affiliated with health system. That sort of aligns geographically. And then very few are located east of Wake County, and also very few are located in rural areas of our state. So what we are seeking to do is to introduce a bill that would be entitled An Act to Improve Access to Patient Care Services via Collaboration Between Physicians and Pharmacists. The general purpose of this bill is to modernize and enhance our existing collaborative practice statute and to better facilitate implementation of collaborative practice in all patient care settings, thereby increasing or improving access to patient care services. For your information, this is our homepage. So the NCAP homepage at www.ncpharmacists.org, and that on the homepage where you see the circled legislative updates, government affairs box, if you click on that government affairs tab there, it will take you to a page where the posting for November 2018 is about our Collaborative Practice Authority bill. And there are a number of links. There's a link to an infographic. There's a link to talking points. There's an editorial about the bill. There's a draft summary of the proposed changes. And then the final document that is there right now is actually a set of comparison maps. They're national comparison maps. So it's basically how does North Carolina compare to other states in the union on various elements about collaborative practice. And I'll share one of those maps with you in just a few minutes. So the key elements to our bill, in other words, what are the proposed changes? So first and foremost, we're looking to open collaborative practice to any physician, any pharmacist in good standing with their board. We want a more open and flexible type of collaborative practice so that we can bring care to patients in all practice settings and do so in a way that has fewer restrictions or barriers. We want to make the language within the existing statute regarding agreements be less restrictive so that we can foster more innovative types of collaboration between pharmacists and physicians. We also want to reduce regulatory oversight regarding the establishment of contracts. So give the power of what goes into an agreement to the physician, or in the case of an institution, the institution itself, and change from a committee approval to a registry process. We also want to allow the physician to determine the number of pharmacists he or she deems appropriate to collaborate with or to supervise. And we want to allow a physician's other advanced providers, such as PAs and nurse practitioners. So, in other words, in a practice, if a supervising physician has PAs and NPs working with them, that supervising physician has the ability to grant permission to the PA and nurse practitioner to also participate in the collaborative practice agreement with the pharmacist. But the supervision would remain with the physician. We are also looking to change the fee structure to a smaller annual fee that's geared, that's actually tagged to the clinical pharmacist practitioner, not to each individual agreement. So, what are some of the limitations of our collaborative practice authority? So this language, this restrictive language that we're referring to. So first of all, we're seeking to actually allow for any physician, any pharmacist in good standing. So this first part up here, this gives certain pharmacists the ability. So currently, it gives certain pharmacists the ability to engage in collaborative practice with physicians. And so how do we compare? There are 33 other states that allow any licensed pharmacist, any licensed physician in good standing to be able to collaborate. We also want to look at the language within our existing statute. It dates back now more than 2 decades. So our language is, compared to most states, our language is some of the most restrictive in the nation. It makes very difficult, if sometimes impossible, in some cases, for physician and pharmacists to craft an agreement, particularly in today's more complex patient care needs around things like transitions of care, where our existing statute language says that it's predetermined drug therapy, it's physician, pharmacist, patient, disease specific. And so when you think about that, the ability to craft or write a written agreement around seeing patients in transitions of care when you may not know initially what all a patient has condition-wise or what all medications they may be on, it does make it a little challenging to try to craft an agreement that would be accepted under our current rules. So this part about physician only too, we talk about allowing the ability for nurse practitioners and physician assistants to collaborate. There are 28 other states which allow other prescribers such as NPs and PAs to collaborate with pharmacists. So the changes that we are seeking are not cutting edge even or unique, and hence sort of our general purpose of modernizing, like bringing our statute where we were a pioneer into existence today with the needs that we have for patient care, and to get us sort of back on track. We've been surpassed by a number of other states at this point, and the types of collaborative care that are being provided in those states is significantly different than what we have in North Carolina. And so where I showed you that we had 294 CPPs in North Carolina, if we just, it's hard to compare apples to apples, but because every state is a little different. But if you go back in time and you look at the 3 pioneer states, Washington, New Mexico, and North Carolina, New Mexico and North Carolina chose to go the advanced credential like CPP. Washington State is one of the 33 that has a more open collaborative practice authority. You look, today we have approximately 300 pharmacists that are engaged in collaborative practice agreements, most of them affiliated with health systems. But if you look at Washington State, they have over 30,000, so 30,000 practice agreements, collaborative agreements in place that are active at any one point in time. So continuing along, talking about the less restrictive language that we are seeking. So this is our general statute 90-18C, subsection 3A. This would be revised to read as follows. And essentially what I wanted to highlight here is that collaborative care services are patient, so this is more of a definition where collaborative care services are patient care services authorized by a physician and delegated to a pharmacist for the purpose of drug therapy and disease management. And then here at the bottom, under a collaborative practice agreement, a supervising physician may delegate to a licensed pharmacist any patient care services the supervising physician deems appropriate. And in the case of an institution, there's another subsection that spells out that these can be agreements that are institution-wide. So instead of having a list of possible services that could be become obsolete in a matter of another decade, or new emerging ways of utilizing pharmacists to help with patient care, we have chosen to go with a more flexible language, similar to the language that is in Wisconsin's collaborative practice statute, where it basically states that the physician can basically delegate whatever they deem to be appropriate for the pharmacist to do. So things that we currently see CPPs doing: ordering labs, initiating, modifying, or discontinuing therapy. This does not make that go away. Currently, if a CPP has the authority to write labs or to modify therapy, that has to be written into their agreement. So this new flexible open language does not prohibit, it basically gives that authority for agreements to be written to include those types of practice services as well as other types of services that maybe the pharmacist can help with. Removing restrictions to improve access to patient care services by patients in all settings. So any pharmacist, this is again that going back to that more open type of collaborative practice that those 33 other states have. Any pharmacist under the provision, and this is the provision that basically grants our CPP, may perform collaborative care services and use the title clinical pharmacist practitioner. So let me first talk about the any pharmacist piece. So this is the map where it shows the 33 other states that allow for any pharmacist, any physician in good standing to collaborate. And I've already mentioned the open, when you have a more open ability for collaboration, you have a variety of types of model of care that can emerge. You have more patient care services being provided, and you give greater flexibility to the physician and to the pharmacist to craft the agreement based off of the patient care needs in their setting or in their community, etc. Speaking to the CPP part, so modernizing collaborative practice here in North Carolina within the existing CPP framework. So if there is a pharmacist, should this bill be passed, if there is a pharmacist that engages in a written collaborative practice agreement with a physician, then that pharmacist would be registered with the Board of Pharmacy as a CPP. A CPP, we are not dismantling CPP because there have been some concerns that we're doing away with CPP. That is not the case. We are looking at utilizing the existing framework primarily because of several reasons that I'll illuminate here on this slide. So if North Carolina did not already have the CPP credential or process in place as our means of carrying out collaborative practice authority, and if we were looking today, like if we were a state like Alabama that does not have collaborative practice authority, if we were looking to start it, we would probably be like these other 33 states where we would be going after any pharmacist, any physician. But because we have the CPP in place, and we've had it in place since the 1990s, it is a part of who we are and how we practice in North Carolina. So North Carolina has incorporated the CPP into our health system's credentialing and privileging processes. We do not want to interfere with how hospitals operate, how they credential and privilege their pharmacists. So we do not want to do away with CPP. The other thing is that CPP is the recognized designation for pharmacists who have been authorized any prescribing duties, whether it be initiate, modify, or discontinue. So if that individual pharmacist in a collaborative agreement has been granted the authority to initiate, modify, or discontinue therapy and writes a prescription, it is the CPP designation that sort of makes that prescription valid. So we cannot dismantle CPP, but we can be more inclusive and less restrictive in how we operate or operationalize collaborative care, collaborative practice in our state. So I sometimes get asked, well, what about provider status versus collaborative practice authority? North Carolina has an old statute on the books. It was written around malpractice, and it dates back to the 70s. And in that statute, it refers to healthcare providers, and pharmacists and pharmacy are listed within the statute as healthcare providers. Due to provider status recognition not being passed at the federal level, the national associations are now calling on the states to work towards passing provider status at an individual state level. So I've been asked, since the national associations had started calling on states to work towards provider status designation, I have been asked, well, why are we focused on modernizing our collaborative practice authority versus going after provider status? And one of the reasons is that we already have this existing statute on record. And so as we look to modernize our collaborative practice statute, we have included a statement within our proposed language which references this earlier statute regarding pharmacists as providers. So if we are providers for malpractice purposes, then we are providers. We are healthcare providers. So we're just illuminating that, bringing it forward into our proposed bill and sort of highlighting, instead of asking to be designated as healthcare providers, we're stating that we already are based off of this earlier statute. So the language included, including provider recognition within our bill, is exactly that. Pursuant to this older statute, which is 90-21.11, a licensed pharmacist is a healthcare provider. And we're just stating that matter-of-factly into our bill. So how does modernizing collaborative practice statute help with payment for services? Because that's part of what the provider status designation is all about too. So most states that are running provider status bills at this time are doing so to gain payment from their Medicaid programs. So last year it was Tennessee and Arizona. There are a number of states out there that are running bills, and basically their primary focus is on getting that provider status recognition for the purpose of getting paid through Medicaid. Here in North Carolina, we have CPP as a recognized designation for payment by North Carolina Medicaid. So modernizing our collaborative practice authority and making it more easier to facilitate collaboration between pharmacists and physicians means that more pharmacists would be able to utilize the CPP credential for billing. But that's just Medicaid. So these states that have been successful or that are currently running bills for being recognized for payment by their state's Medicaid are among the 33 states of any pharmacist, any physician. We already have the Medicaid payment piece, but making our collaborative practice authority less restrictive and more open to the any pharmacist, any physician language gives us or provides us with better leverage when approaching other payers. So similar to the process that Washington State has been going through over the past couple of years, they're beyond. They're like us. They already have the Medicaid piece. But what they're working on now is recognition and credentialing and payment through their private insurers. Getting our collaborative practice authority to be more open, where more pharmacists are collaborating, gives us greater numbers to be able to have greater leverage to go after these payers for payment. We're claiming we already have the provider status designation. We already have the Medicaid component for billing. Now what we need to do is modernize our collaborative practice authority, and then we need to be able to gear up and be able to move towards payment from other payers like Blue Cross and Blue Shield and United, etc. So now what I'd like to do is shift gears just a little bit to talk about the process. So we're in the 2019-2020 session. So this is the General Assembly in downtown Raleigh on Jones Street. Our legislative day is going to be March 19. It's a Tuesday, and we are currently pre-registering individuals. So if you go to our website, which was on the first, essentially near the first slide, if you go to our website, click on meetings and events, you can register for legislative day. There's no charge for registering, and once you are registered, our Policy and Advocacy Committee will work to get an appointment scheduled for you based on your home address with your specific representative and or senator, depending on their schedules. So the 2019-2020 legislative session, every 2-year window has a long session and a short session. The long session is the odd years. It typically runs from about mid to late January until August, sometimes later. The short session is in the even years and typically runs from late May to about mid-July. The House is made up of 120 members or 120 districts. And I point out the House because we have Representative Wayne Sasser, who is a pharmacist, who he's in his first session with the General Assembly. He was elected from Stanley and Cabarrus counties, which is District 67. So I point that out because we have a pharmacist in the House who can be a great ally for us as we begin to run pieces of legislation, whether they're about this or about PBMs or about whatever our needs are as a profession. So I have this little graphic here just to sort of emphasize in a very, very simplistic way, kind of the legislative process. So there will be an idea for a bill. So we have the idea for modernizing our collaborative practice. We have put that information on paper. We have crafted some talking points around that. And we are now seeking sponsors in the House and in the Senate. Ideally, we'd like to introduce a bill in both the House and in the Senate so that the companion bills will be running simultaneously in both parts of the General Assembly. So your sponsor will take the bill to the bill drafting office. And once it goes through the bill drafting office, it'll then have a bill number assigned to it. Your sponsor would then introduce the bill. It's going to immediately go to the Rules Committee. Eventually, it would be read out of the Rules Committee. It may possibly go to, well, actually, it will go to other committees based off of our new processes within the General Assembly. But it will go to other committees. But eventually, if your bill makes it through all of these components and we are able to build the support that we need from members of the House and the Senate, eventually the bill would be read out and called for a vote. And then, of course, a vote in the House. If it passes the House, a vote in the Senate. If it passes Senate, then we'd have to marry up those two versions, make sure they're the same before actually that would go over to the governor for signing into a law. So that's the legislative process. So legislative process is all about making a law. They're often referred to as statutes or acts, and at the local level, they're referred to as ordinances oftentimes. Anyhow, the laws are passed. In this case, we're talking about passed by our state's General Assembly, so state government. But how a law gets enacted is through the regulatory process. And so regulations are also known as procedural rules. So there's a rule-making process, which is used to put together the rules that would enact a law and provide the oversight. And so the oversight belongs to specific regulatory agencies. So at the federal level, that might be something like the FDA or CMS or Department of Transportation or DEA. On a state level, particularly for this specific bill, we're talking about a joint rules-making process that would involve the North Carolina Board of Pharmacy and the North Carolina Board of Medicine. So in your law, you usually want your statute to be more general, less specific, so that there's greater flexibility. It's not as greatly impacted by time as decades go by, and you're not having to constantly update the specifics of the law. Whereas the regulatory side of it, we're typically talking about more specifics or details as to what must be adhered to in order to be in compliance with the intent of the law. So our bill, once again, is entitled An Act to Improve Access to Patient Care Services via Collaboration Between Physicians and Pharmacists. It's all about modernizing and bringing us into compliance with model language that has been put forth by the National Alliance of State Pharmacy Associations, and that model language has also been endorsed by the American Pharmacists Association, the American Medical Association, and the American Association of Nurse Practitioners. Our proposed changes would make it easier for physicians and their care team to collaborate with pharmacists, particularly in rural areas, but it would also help for expanding care in all practice settings, including our health systems. And then physician-pharmacist collaboration can help build capacity and increase access to community-based healthcare resources for patients with substance use disorders and other chronic illness, as previously mentioned. So here's that slide where I mentioned the chronic disease burden, our shortage of healthcare providers. We know that we have we have more pharmacists. A job market for pharmacists is really it's really poor. So we have the ability to create new opportunities and using collaborative care to help plug some of the gaps in care. So as we think about this, as I mentioned when I first started out, thinking about sort of behind the scenes, how could collaborative care help with the citizens' could help with, of North Carolina can also help with healthcare in general here in our state. This is some of the ideas. So modernizing our collaborative care means greater access to care for patients. We're talking about, services that could help with chronic disease management for things like hypertension, high cholesterol, chronic pain, COPD and asthma, medication-assisted treatment for opioid use disorders. There's a great need for pharmacists to be more involved in long-acting injectables, particularly for mental health patients. We have the ability to use collaborative care process for a starting treatment for point-of-care testing for things like a positive flu or a positive strep test. We could also use collaborative care to improve care through medication reconciliation and transitions of care. So instead of just recognizing that there are discrepancies in the medications, having the pharmacist be able to actually write the orders that would reconcile or resolve the discrepancies that are detected. Handling common insurance issues around therapeutic classes. So, for example, a patient has a new prescription for a particular, let's just say ACE inhibitor, and their insurance doesn't have that on their preferred, as one of their preferred ACEs or preferred whatever class of drug, but they do. But normally what ends up happening is the pharmacist has to call the physician's office, this drug is not covered, or the patient can't afford it. And this would give, under a collaborative practice, particularly maybe in rural settings where there's only a handful of doctors that do the vast majority of patient care in a county or in a community, there's the ability to write collaborative agreements around therapeutic class, handling insurance issues. So also handling refills for established patients. So, you have your 72-hour emergency fill, but through collaborative care, there would be the ability for the physician to grant the pharmacist the ability to handle some additional refill authority so that patients don't have to do without medications, giving them time to get back into the physician office to be seen. So that is the information that I've wanted to provide to you today regarding our collaborative practice authority bill. We also want you to feel free to contact us here at NCAP. You can email me, call me. I welcome your questions, comments, and suggestions regarding this bill. Here's my contact information in the pharmacy, the number here in the office, as well as my email address. And then there is a panelist recording to accompany this presentation. So please make sure to click on the link to actually listen to the panelists' responses. And I thank you for listening, and I look forward to working together to modernize our collaborative practice authority here in North Carolina.